Perfect. So welcome, everybody. This is the 52nd webinar by iBreastBook. And every October time, we do a webinar that is mainly patient-focused. It's this time it's about survivorship issues. And it's great to have many serial offenders that have been with us on the webinars before, but many new faces to be on the webinar with us today. So we have 5 short talks. The first is by Kirstin Litz about fear of recurrence. Then we have Jackie Wright from Future Dreams, talking about trying to return to normal. Then we have Fiorita Poulakaki from Greece, is going to talk about survivorship issues from the Europa Donna Foundation. Then we have endocrine therapy for surgeons. Practical pearls for managing menopause, bone loss, and sexual adverse effects by Liz Oridian. It's great to have Liz again with us. And then the final talk is about flat mastectomies by Jenna Morgan from the UK. After that, we'll have lots of discussion, and it's great to have with us Terri Coutee from the States and Giuseppe Catanuto from Italy for the discussion. This webinar have 1.5 CPD points by the College of Surgeons of Edinburgh. So everybody that attends a reasonable amount of time will be able to get a certificate for that. Also, I will send you all the certificates in about a week's time, so just give me some time. Don't start emailing me just immediately after the webinar. If you want to have any questions, please put it on the question and answer section. Please don't put them on the chat, because sometimes the chat function does not, you'll not be able to follow things up. I think the chat is still disabled. I'm going to enable it now in a few minutes once we start the talks. And I think the first talk is about fear of recurrence, and it's Kirstin Litz who's going to share her experience with us. Kirstin, the next 10 minutes are yours.
Thank you so much. Let me share my screen. Is my screen being shared? Yes. Awesome.
Perfect.
Yazan, thank you for asking me to speak today. I'm Kirstin Litz, and I'm here to chat open and honestly with you about my fear of recurrence. Hold on. There we go. I would like to start with some background so you know a little bit about me. On October 27th, 2014, my oncologist called me to let me know the findings of my routine mammogram, the 3D ultrasound, and the MRI all agree. I did indeed have a tumor that was stage 1 breast cancer and DCIS in my right breast. Treatment would be a mastectomy to remove the cancer. Whoops. At the time, okay, no hands on the mouse. At the time, I did not think that breast cancer ran in the family, but cancer did. My paternal grandfather had prostate cancer, which metastasized into bone cancer. In 1983, around graduation from high school, he died from the cancer. In the early 2000s, my father was diagnosed with prostate cancer. By this time, we talked more openly about cancer, which was a blessing. I sent a heartfelt letter to him, letting him know I loved him and that he would be fine. But now it's my turn to call him and let him know that I had breast cancer. My mother had often referred to me as my father's child. Thus, this was extremely hard for me because I believe that our cancers are related. 50 days after my initial diagnosis, according to the Oncotype DX test, I would not benefit from chemo. And since the tumor had been removed, radiation was off the table. I was now a survivor. Via text, my father welcomed me to the Survivor Club. The initial treatment was over. It was now time to deal with survivorship plan that I had heard so much about during my research. Being an engineer, I expected a paper copy of a step-by-step plan with milestones. The plan that I can now recall was tamoxifen for 5 years and oncology appointments every 3 months with corresponding blood tests to check for markers. But just because my initial treatment was over, I was not at the end of my journey. There was much more to come. The cancer journey is physical, mental, and emotional. I visited my PCP to catch her up. We were good friends, and I spoke openly and honestly with her. I told her I feared a reoccurrence. She asked me if I worried about getting hit by a bus. I replied no. Moral, If it happens, it happens. I still try to live with this attitude. However, it is hard. Since last week, the local crossing guard that I've seen every day for numerous years doing his job was hit by a car. He never showed any signs of being worried about being hit, but it happened. Are there signs of reoccurrence worry? Or is it only if we share this fear with others that it's real and acknowledged? Reoccurrence worry is not physical, it is mental. I asked a lung cancer survivor this past Tuesday about reoccurrence, and her response was, after 25 years, I don't think about it. You shouldn't either. How? When so soon after my diagnosis, I had friends that started to be diagnosed. I was now the expert, and I always hoped and prayed for the best. With the advancements in technology and treatments, the outcomes are so much better than in the past. I never spoke about reoccurrence to them. It's not their worry, it's mine. Around my second cancer anniversary, I spoke publicly during a company award ceremony about my breast cancer. Coworkers were shocked and could not believe that I had recently fought the disease. I did not physically look any different, and I did not miss much work. One coworker stopped me in the hall and told me he had new respect for me. Thanks, my metal psyche really needed that. The checkups with my oncologist ended with, keep up the good work, all is well. I'll see you in so many months. Keep taking your tamoxifen, great to see you. At the 5-year mark, research showed staying on tamoxifen would help with reoccurrence. So I continued to take it. That was the complete discussion about reoccurrence. Whoops. By this time, I had more breast cancer survivors as friends. We have things in common that non-survivors just don't get: the weird pains, the foot cramps, and the worries every time something in our person feels off. Then the annual mammogram comes with stress. I still remember the occurrence. I still remember the initial one in 2014. The technician said everything looked good. She meant the images were good. She was not allowed to say anything about what she saw. Back then, I didn't worry about the results. I knew I had dense breasts and that the letter telling me this would show up in the mail. I used to joke about having dumb breasts. Now I uncomfortably wait for the results and the chance that all is not well. I still get the dense breast letter. At the 7-year mark, we ran the breast cancer index test at a cost of 30,000 American dollars. The blessing is there is only one company that has this test, and they won't fight your insurance to completely cover the cost. The results confirmed that I should continue with the tamoxifen until year 10. I'm at year 9 and facing the thought of not being on an estrogen blocker. This year, I have lost one of my best friends to metastatic breast cancer. She was 52 years old and left $2 behind with no parents. I have numerous friends that are on their second or third diagnosis, both metastatic and new cancer diagnoses. This is like a take a number machine at the ice cream shop. At some point, will my number come up? I hear about changes in screenings, different treatments, and new strategy for tumors. I had breast cancer. Thus, why does it bother me so much? Because breast cancer still happens, and it can come back again and maybe again. Changing these items does not change reality. It can come back or start anew. I firmly believe that there are circulating tumor cells in my body. I've accepted this and I live with it. But I feel given the right environment and circumstances, they will gather and create more or new cancer. If we only knew what the right environment entailed, if I eat right, exercise, take my vitamins, get my cancer screenings and sleep enough hours a night, might cancer not happen? My father did that. Remember, I'm my father's child. December of 2022, my father was diagnosed with rectal and lung cancer. Now with my sisters, I'm his caregiver. I've gotten to experience the effects of chemotherapy and sat through his infusion sections. I feel honored to be at my father's side as he goes through this experience. However, it has caused me to think about my diagnosis again. Does this blood test I take every 6 months really tell you all? Will the mammogram I have at the end of this month come back clear? They did not catch my father's cancer during a colonoscopy. Here's what I firmly believe. A more complete survivorship plan might be helpful. I think it is time for us to face this incomplete plan. So curious survivors know what to expect after year 10. When recurrence can happen according to a March 2022 article in the Journal of the National Cancer Institute titled "The Incidence of Breast Cancer Reoccurrence 10 to 32 years after primary diagnosis." Lucky part is the list of reoccurrence criteria: high lymph node burden, large tumor size, and estrogen receptor positive tumors. I only have estrogen receptor positive tumors. Thank you. I'll take questions if there are some.
Many thanks, Kirstin. We'll try to do the questions all at the end during the discussion, and we'll take two different points. And thank you for sharing your experience. It takes lots of courage to do that. The second speaker is Jackie Wright, and Jackie is from Future Dreams, which is helping patients that have breast cancer in London, and she's going to talk about trying to return to normal. Jackie, the next 10 minutes are all yours.
Lovely, thank you. Just trying to share my screen. Okay, so yeah, my name's Jackie and I'm a breast clinical nurse specialist, and I've been working with individuals with breast cancer for the last 20 plus years. I'm based at Future Dreams, which is a support centre, both in person and online, for anyone affected by breast cancer. So this presentation is basically about the conversations I have with women and men, carers, loved ones, for somebody who's been affected by breast cancer. So according to the Cancer Research UK, survival statistics based on 5 years is below. So stage 1, 100%, stage 2, 90%, stage 3, 70%, and stage 4 is 25%. But how do we define normal? It's, according to the Collins Dictionary, usual, regular, common, and typical. So the common question I get asked as a clinical nurse specialist is, how do I get back to normal when life feels so far from normal? You know, women and men are dealing with the new body changes, whether it be surgical scarring, surgical changes, chemotherapy related changes, radiotherapy related changes, endocrine therapy, and the psychological impact, loss of confidence, fear of recurrence, as Kirstin's kindly alluded to. We've got self-esteem and the feeling of isolation and being lonely when they might actually seem quite supported. Feeling a loss of control, not knowing how to move forward after the treatment, the physical effect of treatment has finished. Still managing the side effects of treatment, whether it be things like peripheral neuropathy from chemo, altered, weight, whether it's weight gain, weight loss, menopause symptoms, brain fog, surgical pain. It's all very different. And as we know that having a cancer diagnosis can give somebody a different perspective on life. Then we've got sort of returning to work is another issue. How do we return to work? What does that look like? Do I want to go back to the job that I left before my diagnosis? And the expectations from themselves, from partners, family, friends, and work colleagues. So quite a lot of my conversations with those affected is based on that. So for a lot of people, it's juggling. There's kind of no other way to put it. It's about having conversations. having a sense of pressure to go back to the way things were when actually life feels far from it. It's struggling with expectations from others. You know, they get a lot of conversations about, oh, great, treatment's finished, you can move forward, or, you know, you look wonderful, when actually they feel far from it emotionally. And they feel quite isolated or lonely because they, you know, don't have anyone in their direct circles that have been affected. They feel frustrated with themselves because of the treatment and the side effects of treatment. They can't get back to what they feel they should be doing, and that's that word should. I challenge that conversation all the time. It's the ongoing side effects. So if we're on endocrine therapy or targeted therapy, menopause symptoms, brain fog, you know, there's so many to sort of mention in terms of that. And sometimes they're feeling the pressure to go back to when possibly they're not ready, whether that's for financial reasons or no further sick pay or just workplace demands. So sometimes it's a little bit hard to kind of, you know, put all that to place. So sometimes it's a period of acceptance, accepting for where they are right now, not trying to move too far forward in the future, just accepting themselves for as they are is quite important, I believe. And I think one of the things I like in the house and I try to promote is it's great to share everybody's experience, but try not to compare to one another, because everybody's experience and potentially treatment is different. So each diagnosis is different, each treatment plan is different, people experience different side effects at different times. And what will work in terms of trying to manage those side effects will work for someone and not the next person. So what I also sort of mention is with the loneliness and isolation is that all the practical help and support through when they're going through the physical treatment quickly subsides when treatment's over. Family and friends often want to celebrate after it. Great, you finish chemo, or great, you know, you finish your radiotherapy. But actually the person themselves doesn't want to celebrate because actually they're still experiencing it. They're still having to take their endocrine therapy, or they're still having to deal with the side effects. Emotionally, they're not recovered because that could take some months to years for some people. It really just does depend. You know, they have to deal with comments, well, you know, fantastic, your treatment's finished. You know, you must have been given, you know, I feel great because you're in remission or all clear. And sometimes those words aren't used so frequently. And it just gives a sense of frustration mainly. As I said, most people don't always know someone else who's been through a similar experience. So talking to the family and friends is great because it can give support, but actually speaking to someone who's actually been through it, they often find most helpful. And sometimes the side effects of treatment can lead them to feeling very frustrated and things with themselves. Also find that even like supporting a loved one, they don't actually share their true, honest, deepest feelings with one another for fear of upsetting them. So someone might even come to clinic and look very well supported, but actually they're not talking because they don't say what they truly feel because they're upsetting their, you know, or there's a husband, wife, you know, brother, sister, mother, father, it doesn't matter. It's just so they keep everything quite internalized. So it's the expectations. So it's not only expectations from the wider world, but I think it's expectations that individuals themselves put upon themselves. So it's a word of should. I should be doing this by X date and I should be doing that. And that's really hard. And I often challenge that process. Well, who said? Where's it written? And when we kind of talk it through, you just, you know, sometimes it's about just being in the present, being in now, and this is what you're able to do, and actually take pride in that. You know, you've gone through a lot and just recognize that. People often put on a brave face when talking to family and friends, pretending everything's fine, when actually it's really not, because they don't want to disclose how they're truly feeling. And again, I said it's putting pressure on themselves and comparing, because somebody might have gone through a very similar experience and they might be doing X, Y, and Z, but the person themselves can only do X, and for them it's a sense of frustration. So benefit of support services, whether it's somewhere like Future Dreams, is twofold. You know, it's getting that education and that therapeutic support, but actually it's the peer support that I find is probably the most wonderful here. You know, the amount of people that support one another. They, you know, send WhatsApp messages, text messages, and it's just that almost camaraderie that you don't actually have to fully explain yourself because people understand. So it's connecting with others through similar experiences, whether it be through a buddy system, support group, coffee mornings. And it's just like people get it. That's what I get a lot. People, when it's particularly coming into Future Dreams, people get it. It's, you know, they don't have to explain themselves. You know, attending workshops where they can learn about side effects and how to try and manage them. And it's health and well-being advice, you know, encourage the importance of exercise and living a sort of a healthier lifestyle as they can, giving them some control back as to what they can do. And finding other local community support services, whether it's, you know, the local support group, local hospice often run, you know, cancer recovery programs. I know a lot of local gyms in the UK will offer a cancer rehab program, and it's just almost giving that person an encouragement to take the step and, you know, just make small changes, because, you know, things will get back to where they want to be, but it might just take time. So, you know, some of the benefits we've got here from, you know, some of the classes that we run at Future Dreams is just about, you know, meeting others in the same boat is invaluable. You know, it's, you know, attending a workshop where it's full of emotion, such beautiful, strong women all together going through similar experiences. We have podcasts, so loved all the podcasts, raw, honest, and I can resonate. So I think having that sense of where they can resonate and can connect is really important as well. Well done for bringing us all together. I think that's really good. And I really need this in my breast cancer 10 years ago, and it's such an inspirational place. So it just shows you the value of having support, centre support groups, workshops, just to try and connect people, to take away that fear of, or that isolation, that loneliness, and connecting them. And thank you for listening.
That's a great talk, Jackie. And let's remember that Future Dreams will give lots of support for ladies locally in London. There's lots of other organizations. There's lots of
Absolutely.
There's lots of people that are online are from outside. So about 80% of the of people attending the webinars are not from the UK,
No.
not out of the world. But there's lots of important information that is available for you to help your patients on many of the websites, like Breast Cancer Now, like Macmillan, and they are available in different languages. So it's always worth checking that. So thank you for the talk, Jackie. We'll take the questions at the end. And the next speaker will be introduced by Giuseppe. Giuseppe?
Sorry, I was muted. So, hi everyone. Yazan, thank you very much for inviting me. You know that cancer survivorship is one of my 5 favorite topics as a surgeon, and I feel that this is really an issue for a surgical topic and needs to be part of surgical training. And now, as a surgeon, I would like to introduce Fiorita Poulakaki, who is a breast surgeon. She works in Athens, and she's also the vice president of Europa Donna Coalition, which is one of the most important European organizations of patients advocacy. So, Fiorita, the microphone is yours.
Thank you, Giuseppe, for the kind introduction. Thank you, Yazan, for the invitation, and thank you all of you for being here with us this Saturday evening. Who are we? Europa Donna is the European Breast Cancer Coalition, an independent, non-profit pan-European group of affiliated national groups, 47 member countries, with almost 30 years of experience in advocacy. And we make sure that all European women have access to accurate information and quality screening, diagnosis, and treatment from certified breast cancer centers. We advocate for all Europeans to have the right to well-being and fair treatment in workplace, financial and insurance services after breast cancer. I will share with you a few numbers, a few figures about the incidence in the EU. Almost 1 in 4 annual cancer cases that are diagnosed is about breast cancer. And if we want more numbers, back in 2020, the number of breast cancer diagnoses was 576,000 women in 2020. We expect a rise of about 2.3% by the end of the year to be announced. But what age does breast cancer hit? Although breast cancer is related to elderly women, we realized that 21% of women diagnosed will be younger than 50 years. The 35% will be women between 50 and 64 years of age. We realized that this is a prime time in a woman's life. It's the time that women build a career, produce a family, are in a reproductive phase, they're caregivers of a kid, parents, or probably they have a mortgage to pay. You realize how big is all this and what a huge economic impact will have that should be addressed at the European level. So what is survivorship? The definition by itself is already complicated. It's living with, through, and beyond cancer. According to the definition, cancer survivorship begins at diagnosis and continues during treatment and through the rest of a person's life. If we look at the survival rate trends, we realize that the mortality is decreasing. Probably we do something good. We detect.
Sorry, Fiorita, we have problems with slides. We cannot see slides. We just see the first one.
Oh, sorry.
I don't know if Yazan is online or not. Can you?
I am online. Do you hear me? Can you hear me?
Yes,
we can see the slides are changing now. So you are on the.
Okay, I will go through. You see this? You see that?
Yeah. So if you click on the left-hand side, that will be great, I think. Yeah.
Okay. You see this is where the numbers, my nice numbers.
Yeah.
There was also a nice figure.
Yeah.
The definition. And now we're in the survivorship rate trends. So, as I've been saying, we realize that there is a decreasing mortality. We detect earlier the breast cancer with a greater proportion at earlier stages, and also the quality and availability of effective treatments, drugs, and the therapies and the operations itself have been improved. So we have an improvement in quality. Why is this so important? Because we have more cancer survivors than ever, and because we have a personalized plan for each and everyone. The patient is at the spotlight. One size does definitely not fit all. And research indicates that still there are a lot of long-term unmet needs for all the survivors. If we try to identify the cancer care pathway, we realize that in all these different stages, there are different needs for the patients. During diagnosis and treatment for the newly diagnosed cancers, there is an acute need for care. Then at the recovery and adjustment phase, the need for rehabilitation is even bigger. And later, during the monitoring phase, at early monitoring and later monitoring, up to 5 and 10 years, which is the early monitoring phase, we have also different needs. And of course, at progressive illness and end-of-life care, we have a lot of other even more difficult needs. So I survived my cancer. What happens to me now? Many people will live long and healthy lives following cancer. Some may have a range of significant physical, psychological, or social problems following cancer. People can be left with short or long-term consequences, either of the cancer or of what would have been done with their treatments. Others may live with chronic or incurable cancer for many, many years. Here is just a list with all the range of issues, with some of the issues that the survivor can face. And the most common ones are fatigue, sleep changes, cognitive problems, foggy chemo brain, lymphedema, pain and nerve damage, osteoporosis, menopausal symptoms, gynecological issues, sexual life issues. You will hear a lot about them in the next presentation, psychological issues, and of course, work insurance related problems. Some of these health issues may be short-term, but others may be concerns that the survivors will have to face until the end of their lives. Let's see a few things about the emotional concerns. The feelings of a breast cancer survivor looks more like a roller coaster. They can experience a mixture of feelings, from joy to concern, relief, guilt sometimes, anxiety and fear, a lot of fear. Some people may appreciate life even more after breast cancer diagnosis and gain a bigger acceptance of themselves. Some other may prefer to put the experience behind them and feel that their lives continue as nothing has changed. Some women are concerned about their body image, their loss of hair and their femininity. All of them Most of them are anxious about their health and they are uncertain how to cope with everyday life. There are always feelings of fear and anxiety, even as time passes. And of course, there are a lot of challenges emotionally, the fear of recurrence, as we heard, sexual health and fertility concerns. And of course, financial and workplace issues regarding to discriminations for breast cancer survivors. The relationships with family and friends may change, and usually they change because they usually feel lonely and they feel that they are not understood by their social cycle. Survivors may feel some stress when their frequent visits to the healthcare system end after completing their treatment. This is a problem, and that's why we have to plan the follow-up care after cancer with a lot of detail. The patient and the healthcare team should work together to plan the follow-up care, and a patient should have a consistent and a detailed follow-up plan to feel safe. So when the personalized plan will be decided, it will guide the patient through the healthcare for months and years after treatment. It will probably include regular physical examination and various medical tests. It's based on medical guidelines for the specific type of or stage of the cancer. And having a follow-up care plan helps the patient feel more in control, that there's nothing left aside. A few words about rehabilitation. Cancer by itself and the treatments cause a lot of problems, physical, mobility, cognitive problems. Cancer rehabilitation is a supportive healthcare problem, and the main goal is to stay as active as possible and participate in everyday life, participate in family, work, other life roles, and improve your mobility, your flexibility, your balance. Also, rehabilitation helps to lessen the side effects. Pain, lymphedema, fatigue, all this can be decreased by rehabilitation. Another important thing, especially for elderly patients, is help them stay as independent as possible. And of course, improve the quality of their life. The European Commission on the Right to be Forgotten is a very important issue, and we are working really hard on this. The Europe's Commission Europe Beating Cancer Plan sets the need to approach the European Union to beat cancer, taking into account the different stages and courses of the disease, from cancer prevention to survival. The European Commission aims to examine practices in financial banking and insurance services in people with history of cancer in long-term remission. The right to be forgotten refers to the right of every person with cancer experience to move on with their lives. Non-discriminatory access to insurance coverage and financial facilities by making use only the necessary information during the evaluation. Equal access to financial products, including life insurance products linked to loan agreements. By 2025, the European Parliament will call on Europe's member states to implement the right to be forgotten and introduce it to the European law. They will call on all member states to guarantee the right to be forgotten for all European patients 10 years after the end of their treatment, 5 years after the end of treatment for patients diagnosed with cancer before the age of 18. And in the second phase, there will be a consultation with scientific community, patient organizations, banking, and the insurance industry in order to complete this project within 14 months. 3 tips to create the new normal. We should find ways to manage any lasting physical side effects. Eating healthy, exercising regularly can help us feel better after treatment and eliminate any physical side effects. Prioritize mental and emotional health. It's really common among cancer survivors to feel a mix of emotions, from relief to sadness, from anxiety to joy. A few suggestions. Keep a journal to help process any emotions you may feel and keep you in track. Practice daily meditation and breathing techniques in order to relieve the stress and ease any emotional distress. Connect with other survivors. Lobbying and networking can offer a lot of insights, coping strategies, and inspiration for all of you. Don't let any fears of the future stop you from living in the moment. Be mindful, be happy about the present. Focusing on the here and now can help you shift your mind away from fears and worries and allow you to embrace the people and things that matter most. What do we advocate for as Europa Donna on survivorship issues? Recognizing all this growing number of cancer survivors, we give the greater emphasis on patient experience and outcomes, greater focus on recovery, health and well-being after cancer treatment. Of course, a holistic assessment and information and education of the patients and a personalized cancer care planning. Organize routine clinical follow-up visits and availability, of course, of the tests that we request. Tailored support and surveillance for early breast cancer and of life care. And of course, a very important thing that is a problem throughout the whole Europe is to organize enough end-of-life hospices to support the patients at the end of their journey and their families. The next chapter after breast cancer, we might find ourselves facing a new normal. We should stop living with the fear of a second cancer. Let's enjoy the glory over the first one. Trust the follow-up plan. Don't be afraid or ashamed to ask for help. Life is an everyday gift and every moment counts. Thank you very much.
That's perfect. And thank you for the lovely talk, Fiorita. And I think in the discussion, we'll come to the important point that patients can change policies and can make lots of difference.
Exactly.
The correct buttons. And we'll come back to that, Fiorita. The next speaker is going to be introduced by Terri. Terri.
Thank you, Yazan, for this great webinar and forum that you present. So I'd like to introduce Dr. Liz O'Riordan. I'm very honored to call her a friend too. Liz is a motivational speaker. She is a breast cancer surgeon who has had and has breast cancer. She is a published author, not just this book, but another one. So I'm very happy to introduce Dr. Liz O'Riordan.
Thank you, everyone. Let me just get my screen up. There. So I'm going to talk today about how to manage the side effects of endocrine therapy. And I've got 15 minutes and I could write a book on this. So what I want to do is make life simple for you. In a background, this is me. I used to be a consultant breast surgeon, but in 2015, at the age of 40, I was diagnosed with stage 3 breast cancer. I never checked my breasts. I didn't think it would happen to me. And I had chemo, mastectomy, reconstruction, radiotherapy. I had my first local recurrence in 2018, just 3 years later. And I had another one in July this year. And I'm now on palbociclib and fulvestrant for life. I'm in that strange place of the local recurrences. My surgeon described it as weeding the garden where you just keep taking things away. I don't need to take notes during this talk. What I'm going to do is give you a load of resources on a QR code, but this is a bit about me. I wrote a book to help me understand how to cope with breast cancer, because as a surgeon, I thought I knew everything. And as a patient, I realized I knew nothing. I had no idea how to cope, how to make decisions about what was happening to me. And I've then written a book about my life as a female surgeon having breast cancer twice. This is a paper that came together after I spoke at the Association of Breast Surgeons in America this year, talking about exercise and sex. And we came together and published this. And there's a link to it in the QR code coming up. And I'm going to give you some nuggets from that today. What I also have is a huge range of resources that you can use to share with your colleagues, with your patients. You guys don't have time to tell patients half of what I'm going to. I get it. What I'm trying to do is bridge the gap. I've got YouTube videos that could be translated into any language. The Moving Through Cancer book by Catherine Schmitz is the book about exercise if you want to know why. I've also got a podcast where I answer patients' questions. So use me as that gap between what you're telling the patients and what the patients want to know, because I had no idea what people were searching for online until I became a patient, and I was horrified. This QR code I'm going to leave up will send you to a Google document with the links to all the books, all the papers, all the resources I'm talking about, so I can just listen. There are 3 words I want to bring home, and that they are, well, not 3 words, 3 phrases: informed consent, patient choice, and exercise. And I've had a lot of time to reflect on my practice as a consultant breast surgeon. And what I used to do when I saw a woman who'd had her surgery and radiotherapy, I'd say, right, I'm going to start you on a hormone blocker, be it tamoxifen or letrozole. You may get some hot flushes. a bit of vaginal dryness. They normally settle down in 6 months or so. Here's a leaflet, see you in 5 years. And looking back now, I am horrified at the information I did not give my patients. This is not informed consent. What I should have said was, I am going to put you on a tablet that is going to stop you sleeping, affect your mood and concentration, make your bones and muscles ache, ruin your sex life and relationships, weaken your bones, thin your hair, but you'll be fine. Off you go. Even if I'd read that list of side effects out to them and said, you can take this for 5 or 10 years and it still might come back, I had no idea how to help my patients cope with all those side effects. I knew that HRT was off the table. It's a last resort. I assumed the family doctors would know how to help these women, but they were clueless and I was clueless. I had never had any training. I never talked to any patient about sex in the whole of my surgical training, let alone as a breast cancer surgeon. And it was eye-opening for me when I was put into an instant menopause during chemotherapy, and then on tamoxifen, and then on Zoladex, just to see how miserable my life was. Now, I had a 40% chance of making it to 10 years based on PREDICT, and I still thought about flushing my tamoxifen tablets down the toilet because they made me feel so bad. I haven't slept for 5 years because I am waking up dripping in sweat. And it was only an oncologist on Twitter, Richard Simcock, who messaged me after 3 years saying, did you know there's all these other drugs you can have to help with the hot flushes? I had no idea. And I was a consultant breast surgeon. So in the QR code, you'll get a link to the British Menopausal Society's list of alternative drugs you can give women to help with the vasomotor symptoms. They're also referenced in the paper. Things like venlafaxine and citalopram and clonidine and oxybutynin that can all help. The problem is you have to explain to your patients that they are not being given the drugs because we think they are depressed or they're mad. They are being given antidepressants because they can help with the symptoms of the menopause. It's explaining there are options available and making sure that everybody involved in that woman's care knows how to treat them. Because you may assume they know, but they don't, and women go round and round in circles. We know that 80% of your patients have ER-positive breast cancer and are going to be given hormone blockers, but they reckon that 1/3 to half of patients stop taking the tablets or don't take them all the time because of how they make them feel. And I think it comes down to, again, informed consent and patient choice. We can put a woman on tamoxifen for 5 years when PREDICT or Adjuvant Online tells us they have a 2 or 3% increase in survival at 10 years, but 100% chance of having their quality of life ruined. And we're not helping these patients. We're not talking to them about whether they should stay on them. Do they want to come off? I think it's really, really important that we all tell women how to cope. And the biggest thing that can help with almost every symptom of these drugs and all the other chemotherapy treatment and reduce the risk of it coming back by up to 40% is exercise. There's a great book in that leaflet telling you why we should be exercising, all the science behind it and what our patients should be doing. It works for everything. It works for fatigue. It works for the aches and pains. It works for the hot flushes. It can help with the mental symptoms. It should be a contract. We are going to treat patients to the best of our ability with the latest drugs, and they are going to exercise and look after themselves to give them the best chance of staying alive and to help with the symptoms. But what I really want to talk about in the few minutes I've got left is to talk about sex, because it's a basic human right. And yet breast cancer treatment can destroy the sex lives of women and men. Your libido disappears. Your vagina feels like it's lined with sandpaper. I got labial skin tears cycling for 30 minutes, and I'm used to riding for hours in the mountains. I cannot tell you how horrific it was. I wanted my husband to divorce me, to go and find a woman who worked, because I was broken. Nobody knew what to do. And this is one of the big things in this paper, that we should talk to every single woman about the impact of hormone blockers on her sex life and give her help and appropriate counseling and equipment to get through that. In a nutshell, it's 4 things. It's about eliminating irritants, so making sure they're not using vaginal deodorants and soaps that have got chemicals in. It's about moisturizing, lubricating, and addressing the pelvic floor. And the big thing is vaginal estrogen. Now, as a breast surgeon, I would never have prescribed vaginal estrogen to any patient because I was so scared that their breast cancer might come back. And I'm sure a lot of you out there are feeling how I feel at the time. No, they can't have it. They've got an ER positive breast cancer. There is no way they are having estrogen vaginally. As a patient, I would have hated myself. And I'm incredibly lucky that my own oncologist is happy for me to continue having vaginal estrogen, even though I have my 2nd local recurrence of an ER positive breast cancer. All the studies done on Vagifem were on the old dose when it was 25 micrograms. It's now 10 micrograms, less than half. It's an ultra low dose. And if you take Vagifem twice a week for a year, that dose of estrogen is the same as 1 daily HRT tablet. It is absolutely tiny. There is research now to show that it is safe, whatever that means, for women on tamoxifen, meaning it doesn't increase the risk of local recurrence. The jury is out when it comes to the aromatase inhibitors, and there's only been 1 trial, a Danish trial, which showed that it might increase the risk of recurrence for women on an aromatase inhibitor. But this was done in 1997 to 2004, before HER2 positive breast cancers existed, and 1/3 of patients weren't taking aromatase inhibitors. But I want to come back to what is safe. We know that breast cancer can come back in 1/3 of women despite optimal breast cancer treatment. We know that if we tell them to cut down alcohol and to exercise regularly and to keep their weight healthy, it can halve their risk of recurrence in some cases. This is a no-brainer, but we don't tell them to do it. But we are so scared about this tiny amount of estrogen absorbed vaginally that would have a huge impact on women's lives. We are saying no. And women are going around in circles to their GP, to the gynecologist, to the surgeon, to the oncologist, all saying, no, you can't have it. I am the gatekeeper of the quality of the rest of your life. And I think it comes back to informed consent and patient choice. There may be a tiny, tiny increased risk, but if I'm exercising and I'm not drinking a lot and it's my choice and I want to have sex with my partner and I don't want to feel like I have cystitis, I should be able to have vaginal estrogen because I can go and I can smoke and give myself lung cancer and you're not stopping me doing that. So I just really want you to think about the drugs you are giving these women have a massive impact on their lives, and it's not good enough to say, here's a leaflet, off you go. All the advice to help them is in the paper there, and I think you need to go away and read it and act on it, and let's actually help these women live instead of merely being alive. Thank you.
Great talk as usual, Liz, and thank you for sharing the QR code. Lots of important information that's relevant to many people in different parts of the world. And now, last but not least, is Jenna Morgan. As Jenna is one of the academic surgeons in Sheffield, and Jenna is going to talk about flat mastectomies, because we all talk about how we do a nice reconstruction or do an oncoplastic procedure and make the breast look better, but many times you don't get the flat mastectomy right. So it's a very important issue, and Jenna is going to talk to us about that.
Right, can you all see my slides and hear me?
Perfect.
Brilliant, thank you Yazan for inviting me to talk about this subject in this survivorship webinar. So I'm going to talk about flat mastectomies, or what was always termed to me as simple mastectomies. But is it really that simple? It's not moving on.
Sometimes click again on the screen, it works okay.
Yeah, brilliant, thank you. Okay, so as I'm sure all of you will know thousands of women each year undergo mastectomy for treatment of their breast cancer, of which more than 2/3 stay flat without a breast reconstruction. And there are several reasons why a woman might not have a breast reconstruction, but importantly, they include patient choice, whereby the patient simply prefers to stay flat rather than have a reconstructed breast, or that they don't want to undergo any more surgery. They may be deemed high risk for long or complex surgeries, perhaps because of comorbidities. They may be advised to go flat by their doctors in order not to compromise their oncological treatment by risking complications from the reconstruction surgery, or to avoid the impact of other cancer treatments on the reconstruction. They may not have any options for reconstruction in terms of autologous donor sites, for example, or dare I say it, they may not be offered reconstruction. And this particularly applies to older patients where there is a healthcare professional age bias and presumptions that often older women can't have or aren't bothered about reconstruction. So before I go on, I'd just like you all for a moment to picture in your head a woman who has had a mastectomy, what we call a simple or a flat mastectomy. Okay. And I'm sure most of you had an image similar to this in mind. I think as surgeons, we would all like to think that we're leaving our patients with this sort of outcome following a mastectomy. But in reality, there's significant variation in what I would call the cosmetic outcomes of a mastectomy. Sadly, poor cosmetic outcomes are quite common with mastectomy without reconstruction. And these are some very common problems that we see routinely. So medial or lateral skin excess, often called dog ears. Skin tethering, where the skin flaps have possibly been taken thin in a certain area or unevenly, and the skin sticks down to the underlying muscle. Problems with wound healing and infection in the post-operative period can lead to poor quality scar formation or hypertrophic scar formation. And the one on the right here appears to cross the midline, so it might be visible in low-cut or V-neck clothing. Patients can be left with ridges of tissue, particularly in the inframammary fold, where the fascial layer isn't destroyed, and it can lead to a step or a ridge. So instead of being a continuous flat contour. And this also risks leaving some breast tissue behind, so thereby compromising the quality of the actual mastectomy. And these are some examples at the extreme end. And as you can imagine, poor outcomes such as these can impact on a patient's quality of life, on their body image. It might affect their relationships and their ability to be sexually intimate, as well as interfering with the fit and comfort of bras and prosthetics. And particularly when you get these sort of indrawing and tetherings, you can have problems with range of arm movement. They can be areas where patients get fungal infections. They're difficult to keep clean and dry. And sadly, results such as these are not actually all that uncommon. And I suspect most women are not prepared for this kind of outcome. It also seems that women rarely complain about their cancer treatment and are often unaware that things like scar revision surgery might be available to them. In addition, some surgeons, and definitely not all, but some presume that because these women didn't choose a reconstruction, that their cosmetic appearance isn't a priority to them. So I'd noticed things like this all during my 15 years of training. And together with a colleague at the University of Sheffield, Professor Linda Wild, we wanted to look at this further and see what had already been done in this area. Mastectomies have been around for years, right? So somebody's already looked at all of this. We wanted to see if we can bring about some improvements in these type of outcomes. So in terms of the rationale for looking at this in more detail, despite being such a historic and commonly performed procedure, there's actually very little research into the patient experience of mastectomy and the cosmetic or aesthetic outcomes of what we're calling a flat mastectomy, nor of the healthcare professionals' views and opinions around this topic. And in 2020, the Association of Breast Surgery in the UK partnered with the James Lind Alliance to set up a top 10 research priorities for breast surgery. And they were published last year. And 2 of the top 10 involved mastectomy. Okay. Number 8, what are the outcomes of mastectomy, including those without reconstruction? There's loads of research on the outcomes of reconstruction surgery, but comparatively few on the outcomes of simple or flat mastectomy. And how should this be discussed with patients so that they have realistic expectations and can make informed choices? And number 10 was similar. What is the impact of mastectomy on quality of life? But this particularly relates to women at high risk of breast cancer rather than those who have had a diagnosis of breast cancer. So this has been one of my pet projects for a couple of years now, and alongside my research team, we've got a whole programme of work planned to try and examine the variation in outcomes, understand the issues that women have, and try and identify some of the technical issues to try and help address these deficiencies. So I only have 10 or 15 minutes to talk to you all today, and I'm just going to mainly focus on the results from this part of the project so far. So this was a qualitative semi-structured interview study that aimed to recruit a variety of healthcare professionals across the UK. And we included senior trainees and junior and senior consultant breast surgeons, as well as prosthetists and breast care nurse specialists, as well as nurse practitioners working within breast surgery. So to date, we've conducted 22 healthcare professional interviews nationally, and these were performed between February and May this year. But we've really struggled to recruit from well to the nursing cohort. And so we're hoping to reopen again to recruitment next month. And so shout out to any breast care nurse specialists or nurse practitioners on the webinar this evening. We would like to recruit more of you. So if any of you are interested in getting involved, please do get in touch with me. And I have sneakily put my email address at the top there. If you would like to find out more, we would be very grateful and happy to send you some more information. So the analysis of these interviews were performed using the framework approach, using NVivo. And in terms of results, we identified 4 key themes, and I'm going to go through each of them now. So the first theme that arose was around the characteristics of a good or bad outcome following mastectomy. And there was a consensus that a good scar was one that was well healed, flat, with no excess tissue, and that fit a prosthetic nicely against the chest wall. A minority of healthcare professionals commented that a good outcome was one that the patient was happy with. In general, there were several factors that were thought to contribute to poor outcomes following a mastectomy without reconstruction, and these included post-op seromas, because it stretches the skin and can leave it saggy. Obesity, because it's more challenging to contour at the edges of the mastectomy dissection. And patients were often left with either a lateral excess or a prominent abdomen. And factors that increase the risk of flat necrosis or wound infections, such as radiotherapy or smoking or diabetes. And some of these findings, we performed a local service evaluation where we identified that there was a statistically significant relationship between increasing BMI being positively correlated with poor outcomes such as lateral access and uneven chest walls. So there's some logic here. In terms of surgical techniques, a low scar placement was generally favoured across the interviewees because it avoids it being visible in low-cut clothes. The most common incision used by this sample of surgeons was an IMF-based incision. However, many of these stated their reason as being to aid future reconstruction. And it was all of these, it was difficult to try and disconnect the aesthetic outcomes of somebody that wanted to stay flat with, oh no, but I would offer them reconstruction. Lateral access was regarded as the most common problem, and there were a variety of technical maneuvers surgeons described in an attempt to avoid this, and these included extending the scar more laterally to try and take more tissue, curving the scar upwards, ruching, like you would in dressmaking, to sort of gather up the excess and try and shorten the scar, and fishtailplasty. However, this was not felt to be in common use, and some believed it resulted in poor outcomes because of the shape of the scar. Most surgeons felt that breast surgery was moving in a positive, patient-focused direction since the introduction of oncoplastic surgery, and they felt that most surgeons did consider the cosmetic outcomes of their mastectomies. However, there were a few surgeons, and both the prosthetists, disagreed with this. There was a general feeling that preoperative counselling could be improved, and it could be aided by showing patients photographs of a range of different outcomes following their surgeries. However, almost no one actually practiced this, and this was felt to be mainly due to inadequate appointment times for patients who weren't undergoing reconstruction. And there was definitely a differential in the appointment slot time given to counselling somebody for preoperatively for a mastectomy versus a reconstruction. Several surgeons mentioned that they thought this would be a key role of the breast care nurse specialist. However, we've been unable to sort of corroborate or explore that further due to the recruitment issues we've had. I think it's worth mentioning that the Association of Breast Surgery, who produce a lot of our guidelines in the UK, recommend that they emphasise the importance of showing photos to gain informed consent in breast reconstruction. But there aren't any recommendations in this respect for mastectomy without a reconstruction. There's also some evidence that there is a gap in patient counselling in this area from the literature, with one study finding only 43% of mastectomy patients felt satisfied with the information they were provided preoperatively as to what their scar would look like. Really interestingly, despite all of this, most surgeons felt that their patients' expectations were realistic going into surgery, despite the limited time counselling them. It's important to remember that this patient experience theme is obviously perceived by the surgeon. Opinion diverged about whether age influenced how patients felt about having a mastectomy and their post-operative outcomes. Many felt that relationship status was important, but there was divergence around whether having a sexual partner was a positive or negative factor influencing how patients viewed their mastectomy. It's interesting that a couple of surgeons said they never asked about sexual intimacy or mentioned it because they didn't feel comfortable talking to patients about this. There was agreement that body image was overall negatively affected, and I think this is one of the well-established areas that there actually are in the literature around mastectomy to date. And as I said, clearly these data are inherently limited because these are not opinions from individuals with lived experience. And so we are obviously planning to triangulate these findings with patient experiences, and that will form part of the study that is actually ongoing at the moment. So in conclusion, the main findings were there was a consensus on what makes a good mastectomy, although there was variation in the favoured techniques to achieve this. There was a feeling that exemplar photos should become part of the preoperative counselling process, and patient interviews are currently underway to compare and contrast these results to actually what patients feel is important. These are just my references. And I just want to say thank you to the rest of the team that helped in conducting this research, as well as the individuals from Flat Friends who provided input in terms of the PPI, and Not Putting on a Shirt as well, that provided some of the photos, as well as all of the colleagues that agreed to be interviewed and the patients that are participating. Thank you very much.
That's great. Thank you, Jenna, for a lovely talk. And if anybody wants to take part, especially breast care nurses, in the study that Jenna is running, either you email her. If you struggle to find the email, just send me an email at info@ibreastbook.com, and I can forward that also to Jenna. Now we'll come to the discussion. So if you stop sharing the screen, Jenna,
Yeah.
then we'll have the
How
video.
do I stop sharing?
Oh, let me see. You are viewing Jenna's view options. Stop participant sharing. I've done that for you. That's great. So now we have Terri with us also on the discussion here. And we have also Giuseppe here with us with the discussion. There's lots of disparities between cancer care globally. And also there's lots of disparities in the same country. And there's lots of disparities sometimes and differences on how things are delivered, even in the same region in the same country. And sometimes you need to have some sort of expectation what can be delivered, but what cannot be delivered. But I always tell my patients, you're part of your treatment, and most patients can take lots of active part in doing things. And I think Terri has a story also from the States that when things happened, how the patient group managed to change policies. Terri, any comments on that?
Yeah, we had a rather eventful year in the US in terms of addressing access to DIEP flap. Our overriding government entity called CMS, which is the Center for Medicaid and Medicare, they outlined a lot of the codes that cover the different procedures for breast reconstruction, and they do for all healthcare coding or procedures, I should say. So this year, at the beginning of the year, we learned that the coverage for DIEP flaps was going to be eliminated or sunsetted at the end of 2024, in December of 2024. And so patient advocacy got on board. We raised our voices about it. And on June the 1st of this year, CMS had a public hearing. And so I had to carefully craft a presentation during that meeting. And to be honest with you, I have heard a lot of you. By the way, I'm going to preclude this by saying amazing presentation by all of you. So thank you all so much. What I'm hearing from so many of you is about this insurance coverage, which is one of the huge healthcare disparities that I think breast cancer patients deal with across the globe is what I'm hearing from a lot of you. And so I didn't know if on June 1st that CMS was really just doing us lip service and having this meeting just to kind of soothe our ruffled feathers. But there was one individual from that organization, and I listened to him and I thought, I think he's hearing our voices. So we kind of sat on it. And in the middle of August this year, the patient voices were heard and they lifted that decision, which we're very grateful about. But honestly, our work is not over, because even in the States, I'm still hearing from surgeons, I'm still hearing from patients that they're battling insurance issues. This is a huge issue in access to healthcare for breast cancer patients. And I don't know if any of the panelists want to comment on this, because after being at the London Breast meeting this year, there's something that Wami Masia said on one of the panels, and it just resonates with me and stuck with me. And he said, breast cancer patients can change policy. So I don't know how many of the panelists are seeing that. I want to follow up with another question too. I think also another thing that I saw on here and heard so often is the benefit of exercise. So Liz, I know you and I have tweeted about this. And Giuseppe, I noticed on LinkedIn this week too, that you said 50% of your breast surgery is survivorship, which is amazing. Absolutely amazing. The other question I wanted to pose to the panelists, and this really has kind of an access issue too, is the resources we're providing for this exercise for breast cancer patients. And my question is, how much pushback do you get on this? Because I think in exercise, what it does for me in survivorship, since I've had it twice, is it is an activity that is completely unrelated to cancer. It takes your mind away from it, if nothing else. So my question is, with the pushback, you can have so many reasons why patients will not want to exercise. So Jackie, Fiorita, you talked about the programs, the awesome programs that you had. Are patients saying, well, I don't have time. I work a full day. I have kids at home. I don't have time for exercise, or I don't feel good today. I've been in treatment. How are you addressing this? So those are two kind of unrelated but separate issues in terms of access and how we are providing these resources, insurance-wise, exercise for breast cancer patients. That is a loaded question, I know, but I will throw it out there to the panelists and let me hear what you all hear in your communities, because Kirstin, I know too, you work with a large group in California with HERS breast cancer. So anybody that wants to take that.
So before we take that, Liz has shared the ASCO guidelines on the exercise, diet, and weight management for cancer patients. It's very helpful. The link is in the chat, so please have a look at that. Also, can we start with Fiorita? Because Fiorita, Europa, Donna is influential in Europe, and it's great to see that they're trying to get a pan-European policy, though there's lots of differences in the different countries. Any small comment on that, Fiorita?
Exactly. This is one of the main goals of Europa, Donna, to implement these things in the European Parliament, and then each and every European country to implement it in the national Ministry of Health. I think it's an issue that should be addressed in the following years. We expect in the next year to start to be implemented. There are very few countries, Cyprus, the Netherlands, and I think Romania, that have started to implement such laws for their workplace environment and insurance policies. And I'm not talking about the reimbursement of reconstruction that more or less is being reimbursed in most of the countries, maybe not for all patients, but for the majority of the patient, reconstruction reimbursement has been achieved in the last 5 to, 6 years, 5 to 10 years probably. But I think that we will see new things, new developments in the next years for the European Parliament. I think at the local, at the national level, because I saw a question in the chat about it, every country, if you want to help the patients in your own country, every country should address to the National Health Ministry, also in combination with the Ministry of Work and the patient organization that is working with advocacy at the country, maybe it's Europa, Donna, maybe it's somebody else, should write a letter on this and try to write a white paper, a declaration, and address this issue. The other question regarding the exercise, my advice to my patient is try to do your best. If you have 15 minutes to walk to your work and not to take the car, do this. If you have young kids and you want to get them to do something, to play tennis or to exercise or to do basketball or something, this hour that you wait for them to finish this exercise, try to use this hour to do something for yourself. Find a gym close to this facility, walk, move, keep on moving. What I like to say to my patient, if you have a body, you are an athlete. You can do something. Keep on moving.
That's perfect. And we'll ask some questions to Liz because Liz has to leave in the next 10 minutes. She has other commitments. Liz, it's all about shared decision making, isn't it?
It really is. And I think you don't need to have had breast cancer to understand what patients are going through, but until you realize how bad the side effects, it's very, very hard. I thought giving high quality of care was a patient with a pretty scar. And I realized when they're miserable, when they don't like themselves, no one taught me about the mental side effects of breast cancer that can kick in, the scanxiety, the fear of recurrence. It does affect every single part of you. And I think we are part of a team. I had no idea what the radiotherapists and oncologists do. You need to talk to the nurses, you need to talk to family practitioners and make sure someone is able to give them the information they need when they need it, because we all want information at different times, and that makes it even more difficult to help men and women with cancer.
I remember a couple of consultations with patients. The patient told me, do I have to take this tablet? Say, no, you don't have to take the tablet, but this is the benefit from the tablet. This is your risk without the tablet. This is the risk with the tablet. And she said, I struggled with the tablet, but since you gave me the option, I wanted to take the tablet because it's my decision. So sometimes that's part of the decision making, if that makes sense. And always keep an open door. Like there was a comment on from one of the surgeons, I think Walid Fahmi online. It's a teamwork. Don't underestimate what the breast care nurses do. The breast care nurses, loads of the consultations that when you finish your consultation, you might tell the patient 10, 15, 10, 20 minutes, half an hour, your consultation about the cancer and the treatments. Don't underestimate how much is the breast care nurses putting after that. A consultation makes clarify everything. And they're your safety net. So it's very important to be part of that team. And we heard from Kirstin about, for example, you're on the tablets, you're on the medication, and some people feel the comfort in taking the tablet. So psychologically feel some ladies feel the comfort that they are on something, and that tablet gives them the comfort. And you see that lack of comfort with triple negative breast cancer patients, because while they're on treatment, they feel that something is happening. When treatment finishes and there's no tablets, even if it's causing the side effects, it's still, they're not taking any tablets and they feel that they're left alone. Any comments on that, Liz?
The worst part of treatment for me was after a year when my surgeon oncologist discharged me and said, we'll see you in 5 years. And I thought, holy, I'm by myself. Is today the day it comes back? Do I worry about a cough? I realized I never told my patients what the side effects were. I never told them how to check their mastectomy to look for local recurrence, because there's never the right time. And you feel so alone with Google as your friend or your enemy. And that's why finding online groups of support or like the Future Dreams is really, really helpful. The hard work starts when the doctors say goodbye and you're left to live with the aftermath, the grief of everything you have lost. It is huge. And I had no idea what an impact breast cancer has, because as a surgeon, it's routine. Yeah, 5 lumpectomies a day, all good. Off you go. Great. Thank you very much. Pass them on to someone else. It may not be your job to understand what is happening to us, but every once in a while, listen to the breast care nurses, see what go and spend some time on Instagram and YouTube, seeing what your patients are looking for to help you then digitally signpost them to safe apps, websites, so they're getting good information than the scary stuff out there.
And may I say, there's lots of information, not only from what Liz have shared. Liz have shared the QR code, which has lots of things. There's Fiorita, there's the Europa Donna website, has lots of lovely publications that are relevant to many patients.
Also, and Future Dreams has also got a great, it's like the equivalent of me as well, all online. There's so much. Breastcancer.org in the States.
And there's Breast Cancer Now. They've been on the webinars before. They have beautiful leaflets. Macmillan has lovely leaflets. Many of those are not only in English. Many of them are different languages. So please have a look at that. That you might be able to guide your patients, or if you're a patient, you might be able to look at those leaflets rather than going on Googling and end up on a website that you really don't want to end up on. Giuseppe.
Yes.
You love shared decision making.
Oh, yes, sure. I can confirm that 50% at least of my surgical work is related to survivorship, because I deal with survivorship when I, let's say, start with pre-habilitation, when I talk to the patient and introduce and explain what is going to happen to her. and tell her that, well, breast cancer biologically is a highly curable disease. And once she will get surgery, radiotherapy, and any kind of adjuvant systemic treatment, she will be biologically healed from cancer, but she will suffer from the consequences of all these treatments. And this is not only something psychological. I mean, it's not only fear of recurrence. I fully understand this, but it's also, I mean, how to cope with a sore breast, how to cope with lymphedema, how to cope with every kind of symptoms. In Italy, we don't deal with systemic therapies, with symptoms associated to systemic therapies, but obviously these kind of symptoms have to be regarded as well. And so again, when I'm doing a surgical operation, I have to bear in my mind to make kind of a projection of the future of this patient in the next 5 or 10 years. We do not discharge patients after 1 year. We take care, fortunately, in the Italian NHS, we still follow patients every 6 months for at least 5 years, and then every year for 10 years. So, well, ironically, Liz is here, and I believe that clinics shouldn't be designed to surgical clinics shouldn't be designed to find local recurrences. I know this is ironic for Liz, but local recurrences nowadays are very, very rare. We should concentrate on survivorship issues. This is very important. And again, use prompts routinely. We have a project nowadays down in Humanitas, in my hospital, for having digital patient monitoring. So it's not only on a predefined time point, but it could be a continuous monitoring of quality of life, of symptoms, and so on. And try also to create a direct connection with the breast care nurses, with all the system, in order that if anything it appears, we can tackle this and we can offer a chance to the patient. And also I have another comment about flat mastectomies. Sometimes flat mastectomies nowadays can be related to, probably some patients doesn't like to have silicone breast implants. There is a lot of media pressure on breast implant illness, on all the problems related to having a foreign object. And, you know, I'm part of the European Society of Surgical Oncology. And once again, I would stress as much as I can the need to understand that breast reconstruction is part of a surgical oncology procedure. It's not cosmetic surgery, it's a surgical oncology procedure and needs to be designed and investigated as a surgical oncology procedure. And we need a lot of development because nowadays we're still using implants, devices, which are, the same devices of more than 50 years ago. And we need a lot of development. If you have fear of breast implant illness, which is something that really does exist, maybe you can be forced to go flat if you cannot go for an autologous breast reconstruction. And obviously, we need to increase the training of plastic surgeon in microvascular surgery to make this kind of reconstruction not only a very good option, but also a very effective option for our patients. So this is how I see the problem of survivorship, either on the oncological side and on the reconstructive side, being an oncoplastic surgeon. And thank you very much for your attention. And I like to stress how important is training on survivorship for breast surgeons. Don't deal only with drugs, don't deal only with surgical techniques, but also try to understand that you have a human being in front of you and you need to make a decision with her.
So let's remember that survivorship issues mainly because patients are living longer. And if you look at the data, more than 95, nearly 100% of stage 1 are living for 5 years, and these are living longer and longer, and that's why they're having more of side effects of the radiotherapy, of the tablets that we're giving them, of bad scars and things like that. And it's part of shared decision making, and it's one of the worst things to see is an awful mastectomy scar that is not flat. The patient cannot have prosthesis, have a large breast on the other side. She cannot fit in her bra. So it does make a huge difference, a decent flat mastectomy. So for information about breast cancer in general, you look at Breast Cancer Now, Macmillan and Europa, Donna. For reconstruction, you need to look at all the options. You need also, it's not a bad idea to look at patient groups like the UFC Foundation with Terri, and there's lots of lovely discussions that happen there. There's lots of clinicians and there's lots of patients on that. Also, Flat Friends in the UK also is quite good. So you need to have all those options. Jenna, any comments? There's lots of questions from surgeons about technicalities. How can we make the mastectomy flatter?
I think I am not going to sit here and say I am an expert and every single one of my, mastectomies is perfect. But I think we're all capable of doing it. We can produce these beautiful breast reconstructions or these very clever, partial reconstructions. We can do all of these clever things. But I think it's about having respect for the simple procedure, and it's about maintaining meticulous technique, even though it's the easy case of the day, respecting the planes and taking your time and not letting it just be the operation that the junior member of the team gets to do. I think it's about paying attention to your markup, having those conversations, looking at the patient at the beforehand, and identifying that actually maybe she has got a bit of excess tissue under the side. So if I take the breast away, fine, that's not breast tissue laterally, but she's going to notice that, and that's going to be more prominent. And actually having those discussions with the patient beforehand, I think everyone is capable of doing a good mastectomy. I think it's about taking care, if I'm honest.
So, and a little question. Somebody's asking, what about flat mastectomy keeping the nipple areola complex? I've seen that done in the Far East. Have you seen
I would say that's out with my area of expertise. I've never done that, and I've not seen anyone do that. Be interesting to find out more about it, but it's not something that I do on a regular basis, so probably not qualified to discuss that.
Giuseppe and Fiorita, have you seen mastectomies going flat with keeping the nipple areola complex for future reconstruction?
No, not really. Only a couple of times if there is a very small breast, the cup A, and the patient is not smoking, is not diabetic, has very good vascular health. But I absolutely agree with Jenna. This is not something we use. This is not something I use, because I'm always afraid of the nipple necrosis, which is a very, very sad complication.
And Giuseppe,
what?
Sorry.
Yeah, did you see that, Giuseppe, at all?
No, I haven't. I got just a comment about flat chest. We need to raise the issue of survivorship for male breast cancer. And I had a lot of requests of breast reconstruction in male, which is, something that we need to consider. Is like flat chest for women. It's something that we need to consider. I had a few men that requested for nipple preservation and requested for breast reconstruction, just because, like women, they don't want to see the scar. They don't want to demonstrate the disease publicly. You are a man. And I said, okay, I'm a man. I don't want to show my breast cancer. I'm feared about this. Obviously, I cannot wear an external prosthesis. When I go to swim, everybody will see that I had breast cancer.
So maybe ask Jackie and Terri about that, and then we'll go to Terry's question. Jackie, have you seen men with breast cancer asking about reconstruction?
No, not in my experience, but I completely understand where Giuseppe's coming from. It is, they do feel very self-conscious going swimming, going publicly. They feel like they can't go topless, so that it is a concern. Maybe it is something we need to consider going forward.
And Terri?
I'm trying to find a YouTube channel. I actually interviewed Michael Singer over in the US about male breast reconstruction. It is not a well-known procedure for men, to your point, Giuseppe. And There are men who would desire to have breast reconstruction. They just simply don't know about it. There's, I think, primarily, from what I understand, you know, in the absence of a medical device like an implant, fat grafting can be done, if I'm not mistaken. You know, sometimes a tattoo would cover a scar or mask some of the effects of surgery. The other, I have a question too about flat closure, because we as patient advocates work hard about vocabulary. And I know, Jenna, I know Kimberly Bowles over here in the US, who is with Not Putting on a Shirt, and I've done an interview with her too. This is my question to all of you, because we've worked so hard about this nomenclature and defining this as aesthetic flat closure. I get some pushback from that community that we're not describing it, or are not describing it. Let me put it this way. We're not listing it under breast reconstruction. It's not breast reconstruction. It's chest wall reconstruction, in my humble and personal opinion. And I think we have to be very careful about confusing patients on this issue, because I know that Kimberly, and she has worked so hard about this term aesthetic flat closure. We both try to promote that in our separate communities. So how important do you think this nomenclature is? I personally think it is, and we have to be consistent, because aesthetic flat closure does not involve a breast reconstruction. I'll leave that on the table for all of you to address, and what your thoughts are on that.
So if I may, so I think in the UK have not quite established our nomenclature as quite as well as you guys maybe have in the US. But there are some debates, having chatted with some of the charities, like Flat Friends, for example, over here, about whether or not that aesthetic flat closure is the right term to use, because I mean, we should be expecting a flat result from a mastectomy as standard, and we should be, you know, in terms of the aesthetics, we should be making it look as nice as we can. So I think that is still up for debate, and that's why I've been very cautious in my terminology today. And you know, traditionally we always call it simple mastectomy, and I know that, you know, that's out of favor now, for obvious reasons. I think it's important probably to establish a consensus. It's just what that's going to be is perhaps yet to be seen. I know, darling, I'm just hang up, sorry. I think it is important to distinguish between the patients who are having a mastectomy and might consider a reconstruction at a later date, versus the patients who come to you and say, I don't want a mastectomy. Reconstruction, I just want a flat chest. And I am seeing plenty of those patients in my clinic, in the same way that I'm seeing plenty of patients that say, I would like a contralateral symmetrizing mastectomy, not a risk reduction. They're not at, you know, they don't have a family history, they're not a gene carrier, they want symmetrizing surgery. And I know that there are, again, there's variation and lack of consensus, particularly in the UK, whether or not we should be offering this. And I personally believe that we should be offering this. It should be a choice for a patient. But I know that not everyone feels the same. So I think there are lots of issues in terms of healthcare providers, and perhaps us not listening or meeting our patients' expectations?
So I think that the contralateral risk reducing or contralateral symmetrizing mastectomy is a full webinar. We can't argue about that for hours and hours. So we'll leave that for a different day. Fiorita, did you have your hand up? I think you're on mute.
Yes, I had my hand up, but Terri completely covered me. We said the same thing regarding the tattoo for men and fat grafting, because I think the reconstruction for a man after a mastectomy is kind of easier with a tattoo, either or with a nipple, with a skin graft, a small skin graft, and a little fat grafting. And okay, we cannot forget that usually men have a hairy chest, so it's kind of easier to somehow hide the scar. But I just wanted to make a small comment on Jenna's contralateral mastectomy. I was actually looking for the link to share with you the previous manifesto of EBCC 14 about the risk reduction surgery. I think Giuseppe was involved also in this project, and we actually gave a few insight about how patients sometimes ask for contralateral mastectomy and what should we advise them against or in favor regarding their personal risk. I will share it with you in the chat. I will share the link with the chat.
That's perfect if you can share that in the chat. There's a comment from Lona McHattie. Sorry, Lona, I could not reply to your email earlier because I'm between jobs. I'm still, we've just moved to England. So you're asking about hyaluronic acid-based vaginal pessaries, which should be safe. And you're mentioning about lobular cancer and the risk from HRT and estrogen products. And last year in October, we've done the webinar. One of full session was mainly on HRT and breast cancer. And it's something that's, there is no black and white in many things. There's many things that we can try. There's many things that we should avoid. And I agree with you. If there's something that is non-hormone based first, that's fine. And that's a better option. I don't have any issues. I prescribe the vaginal estrogen on short-term basis for my patients in certain cases, not for everybody. Now, Kirstin, we always talk about fear of recurrence, but it's difficult to understand the fear of recurrence unless you had the problem to begin with. Is there any way of helping people to move forward? What did you find helpful for you to move forward? It has been 9 years now, nearly 10 years, hopefully.
I think talking about it and having a decent survivorship plan, and it's been discussed here, and I'm very thankful for that, that it needs to be talked to, and we need, when you're going through your initial surgeries and those kind of things, talk about, I think at the time you believe the patients don't want to hear this, and there may be some that don't, but I think that transparency and being able to give as much information up front as possible, even if it's an overload. The thing with Liz and her QR code and having all those resources to go back to, I think is invaluable, because reoccurrence, it's a mental thing. You go through stages as to whether, some days you think more about it than other days, and it all depends because you've got all those other moods that go along. And I think just sharing information, the information about how much exercise it might take in relationship to these things, or the studies, just sharing the studies. And I know that in Terri's Facebook group, it's an amazing place because there are all those resources that we can go to and go back to and look at, and she has all those other resources that I can go back and I go, okay, it's 15 minutes. A 15-minute walk is a great place to start. Being a caregiver at the moment, I will admit I'm very guilty of not exercising as much as I should. So hearing that 15 minutes is like, okay, I think I can do 15 minutes. But yeah, I think it's not a priority. It may be something too that you need to have somebody keep you accountable on, like other things in life. mine, I think about in the morning, oh, I should do X, but then life gets busy. So I think that reoccurrence is always going to sit in the back of your mind. But I think knowing what you can do to help it not happen. I mean, yes, I agree. Tamoxifan's not the best, most favorite thing for a lot of people. But exercise, getting your routine scans, doing whatever else you can is really important. And having that encouragement from your oncologist as you see them, those kind of things, that to make sure my PCP asks me if I exercise, but my oncologist doesn't. So just, you know, checking in and making sure all those things that can affect reoccurrence are being done as well is important.
And the key thing is that many health systems will not give you a clinic appointment to be examined physically. Because that's what the health system can cope with. The most important thing is to know what are the signs of recurrence. I think I've seen a couple of very nice videos online. I think Liz has done one of them. It's great to have that type of education, because education is power. And I always tell my patients, you are part of your treatment. So you always need to know as much as you can. So when there is a problem or there's a potential problem, you call and you contact and you will be seen. Even if it's not a problem at the end, you just need to be seen. Any final comments? It's coming 6:45 now. Any final comments from any of the panelists? That's great. So now the next webinar is a journal club. It's a complete different way of doing stuff. We're joining with the Clue Breast, and it's with Bahadir Guluglu, with Neshlihan Kabiglu, and Kirstin Litz. We have two speakers. We have Oresti Gentilini from Italy talking about the sound trial about omitting axillary surgery in breast cancer, in early breast cancer. And we have Henry Curer from the USA talking about eliminating breast surgery completely. This is on the 18th of November. The also has CPD points, so hoping to get as many of you online. All the webinars, as you know, are free. There's a couple of other webinars already planned for December, for January and February. We'll send you the details more, and hopefully we'll do more better communication with you. Sorry for the loose communication in the past 2 or 3 weeks time. We've been all over the place. Now, Fiorita, Terri, Kirstin, Jackie, Jenna, Giuseppe, and Liz, I cannot thank you enough for being part of the webinar this evening. And thank you for the more than 400 participants to join us today on a survivorship webinar. Hoping to see more in the future webinars. So for people in the States and South America, have a lovely day. For people in the UK and Europe, have a good evening. And for people in the Middle East and the Far East, have a good night. Thank you, everybody.